year.
And is it available? Just a presentation. I'm Dr. Keel. I'm just here in Anderson, South Carolina. I'm of Dow Medical College, Class 8. I'm both nephrology and internal medicine. I'm a professor at the Osteopathic College in Spartanburg. I teach residents and medical students who root with me. I am in the group practice 15 years. So I want to thank Apna Merit for give this talk, and also for Danielle to help to set this up. I want to thank everybody who has come to the lecture. That has selected is an important topic. Very these days our world is chronic kidney disease, staging, and outpatient management. This topic is mostly geared to house office in Pakistan, medicines, and general. So that's some of the knowledge that will share to you in their day-to-day practice. The idea of this talk is that at the end of the talk, we should be able to diagnose kidney disease. We should define what are stages of chronic kidney disease. We need to kidney disease and then discuss the different modifiable risk factors for progressive chronic kidney disease. I will start with a case because I find that it helps to the talk and also helps the audience to this case in future to recall the. So is a 68-year-old woman with diabetes and hypertension who for a routine visit of leg swelling, but otherwise was asymptomatic. Examination showed that her 5 kilograms, a blood pressure 55/90, which is slightly high. Her physical examination showed that she had decreased peripheral, had a right femoral bruit. Other remarkable, edema. Diabetic called hydrochlorothiazide and insulin. That 8 years ago, her serum creatinine was 1.5. Her serum creatinine was 1.6. So, the question: how can we assess her degree of kidney function at this? So the doesn't have chronic kidney disease. One nation of chronic kidney disease. So then is taken out from American Journal of Kidney Disease in 2002, when using the chronic kidney disease. So chronic is defined as presence of markers of kidney damage for more months. Can be as the structural or functional abnormalities of kidney without decreased GFR. Infested by pathological abnormalities or kidney damage, including abnormalities in the composition of blood, urine, or abnormalities in imaging tests. So this is a complicated definition of chronic kidney disease, but to explain it a little easy, basically, if you microscopic or hematuria for more than 3 months, we can say chronic kidney disease. If you have proteinuria for more than, or a plan of your kidney shows that you have echo kidneys, you have suggestive of polycystic kidney disease, or put you into the definite kidney disease. The other definition is you have a GFR of less than 60 cc's months with or without other signs of kidney damage. You assume to have chronic kidney disease. So if GFR is less than 60, if you have no other abnormalities like hematuria or any abnormalities on your renal ultrasound, you will be classified as chronic kidney disease. So the etiology, in the United States, 9 million Americans have chronic kidney disease, and in Pakistan, there is high chronic kidney disease. Unfortunately, it has not been diagnosed on a. We have approximately 500,000 maintenance hemodialysis. What is the prevalence and the number of patients on dialysis in Pakistan? The rate of ESRD is 24%, and that's probably same in Pakistan. So why is it so important? And this that chronic is associated with cardiovascular disease, kidney disease, and mortality. Chronic is high risk for cardiovascular disease, kidney disease, and over mortality. Go back to the case. Her CN was 1.7. So if you go by, we have a GFR. 3 is available to measure a GFR. The most and the oldest equation is called Cockcroft-Gault equation, which uses it to the creatinine clearance. Then we have RD equals again X base. We have a modified RD equation. Last few years we have the chronic kidney disease epidemiology equation. And the Cockcroft-Gault equations are less accurate in populations with normal GFR. So go to the patient has 1.7, So if we put her age and weight, her clearance is 27 C's by Cockcroft-Gold equation. If by the MDRD, her clearance is 32 ml per minute. So we know chronic kidney disease. Her GFR is low, less than C's. So how to quantify chronic kidney disease? This is chronic kidney disease classification based upon glomerular filtration rate and albuminuria. I see this chart. There are ranges that I just want to point out here. One, that which stages of chronic disease. Stage 1 is more than 90 cc's per minute, 0.73 square meters. Then we have 2. The C has been divided into 2 stages. A is from 45 to 59 per minute. Stage 3B is from 30 to 44 minutes. You have stage 4, below 30 cc's per minute, and you have stage 5 called G5. And if we call them G5D, D means for dialysis. They also have come up with albuminuria stages called 1A, 2A, 3. If you have less than 30 milligrams of albumin excretion, then 1. If you have stage 2, it is between 30 and 300, and stage 3 is more than 300 milligrams. So this is literally new, where they have also staging albuminuria. This is where they put the stages of chronic kidney disease along with the albuminuria stages. So if it goes by different color, so you have color, yellow color, orange color, red, deep red. In the boxes are guide to the frequency of monitoring. So dark color you are, the more risk of progression to stage kidney disease you have. So if you have chronic kidney disease as well as you have albuminuria, your of protein is much higher than somebody who does not have albuminuria. So the takeaway from this slide is that if you have albuminuria or proteinuria along with chronic disease, you are at high risk of progression to E. Now that has chronic kidney disease, you make GFR by one of the equations that I mentioned early. MDRD is the most commonly used nowadays. A lot of laboratories have calculated GFR by MDRD and spit it to you, so you don't have to do the work. Once you classify into what stage is, then the step is to identify the reversible causes. So when it comes to you in your clinic, you look and see if they have volume contraction, any obstruction, or is there any effects of medications on the function, such as glycosides, amphotericin B, and recent contrast IV contrast agents. contraction, you want to make sure they are not on any diuretics, they don't have vomiting, diarrhea. You want to make sure they are not have obstruction from in state. These are reversible causes and should always rule things in a patient who has an elevated creatinine. Cause of kidney disease are renal disease, glomerulonephritis, nephrotic syndrome, hypercalcemia, multiple myeloma. All these that I have mentioned can, and of course, improve the function. The two main causes of chronic kidney disease are diabetes and hypertension. After and ruled any chronic kidney disease, and out if this patient don't have any other which can be treated, such as glomerular myeloma, hypercalcemia, nephrotic syndrome. To the management of chronic kidney disease. You have to treat factors associated with progression of chronic kidney disease. The hypertension, proteinuria, and glucose control. Hypertension could be an topic that we can discuss one day. Very prevalent, important kidney disease. The target is 140 over 90. The patient proteinuria, then the pressure is 1 over 80. New guidelines, this is GNC 8, and I think some controversy, and hopefully we have some new guidelines next year. It has slightly relaxed the dose of blood pressure. Always several antihypertensive medications with different mechanism of activity. We can ACE and ARBs. We can have calcium channel blockers, AZ. I'm going to bring out a couple of files because whatever we do in medicine have evidence-based practice. Benazepril Trial is a randomized controlled trial which compared an ACE inhibitor with in 5. This was published in 1996. It's a fairly old trial. The point was doubling of serum creatinine. 31 patients, while 57 of the 283 patients, the placebo doubling. So there was a significant height of doubling of serum creatinine already in the non-ACE. Also, Benazepril group associated with 25 reduction in protein excretion. Since then, multiple have been done, we shown the benefit of or in decreasing the proteinuria as well as the function. Some of the mind is IDNT, renal, and some others. Proteinuria, or whatever you want to call, is the single best predictor of disease progression. Just that is less than 30, microalbuminuria 20 to 30, 300, is more than 300, and nephrotic syndrome is 3 grams in 24 hours protein excretion. Yes, if you can remember, this blood pressure was high, so of course she was TZ. We will provide an ACE inhibitor. Not control the pressure, we can add a calcium channel blocker and try to maintain pressure less than 140/90. The next biochemical abnormality is of chronic kidney disease. All tests and radiographic studies would you order. That could go for another case. W is a 51-year-old Hispanic male who established a new primary care physician. He needs on his medications, but he does not know their names. His medical history is hypertension, diabetes, hep C infection, glaucoma. His symptom shows mild fatigue. Examination shows that he has agitation. His blood pressure is 122/73, which is normal. No elimination otherwise. As following: his white count is 7, his hematity 2, are normal. Hemoglobin A1C is 8.8% high. His renal or in Pakistan is called basic panel. Some people call it here also. Sodium 33, 5.2, CO2 is 19, creatine 2.0, calcium 7.4, glucose 67. That is 3 plus protein. Hep B antigen negative, Hep C antibodies positive. B1 is 29, 28, creatine 0.9. What changes with CKD? You get a decreased hematocrit, bicarbonate is decreased, increase, PTH is increased, and triglycerides are increased. So the metabolic is that can occur with chronic disease. So these are previous the metabolic change or abnormalities associated with chronic kidney disease. The complicated disease. You have load in chronic kidney disease. You have hyperkalemia, acidosis, mineral disorders, tension, anemia, dyslipidemia, and dysfunction. Talk about each topic, and it could be another complete one talk. So, touch on couple complications for primary care physicians as to know. Very disease, dialysis patients, hemodialysis patients with anemia have increased rate of hospital admissions. They have and shown that they have reduced quality of life, improve energy levels, sleep, and quality of life in hemodialysis patients. Briefly about there in 2006 and 2007 important studies because they have changed and chronic kidney disease in dialysis patients. A controlled trial of 603 patients with chronic kidney disease, most stage 3 and 4, and over 3 years. So there are 4 patients, chronic disease and anemia. And a normal hemoglobin of 13 to 15, and subnormal 10.5 and 11.5. The end is a composite of 8 cardiovascular events, and the endpoints included progression of CKD, quality of life. So the first event occurred in normal arm and 47 events in a normal hemoglobin arm. Required in the normal hemoglobin arm and the sub hemoglobin arm. And there were episodes and headaches in the normal group. So what it that hemoglobin had higher of first cardiovascular event, the slightly higher rate of hemodialysis and more trial, and at the same time around 206 published of Journal of Medicine. It is a large, randomized controlled trial, 32 patients, well done. They took a hemoglobin of 13.5 and a hemoglobin of 11.3. Their points were required death, MI, C, and CVA. And the result 25 patients in the high, 97 patients in the low group. There was improvement of life or similar. The high group had at least one serious adverse event. So, trial implemented the quad results showing that the higher rate of cardiovascular in the arms at higher hemoglobin levels. After 2 trials done in dialysis patient of in chronic kidney disease has changed significantly. So we initiate which is erythropoietin stimulants, namely epogen or erythropoietin and darbepoetin. I'm not sure what names, trade names are available in Pakistan. We therapy when the hemoglobin is less than 10. We maintain hemoglobin level between 10 and 11.5. We, the nephrology group, we're targeting hemoglobin above 13. It has 1B recommendation. Hemoglobin targets more than 13 grams are associated with adverse outcomes. The other one of CKD that I want to touch briefly is metabolic acidosis. Complication is quite a bigger picture. A lot of evidence that show that metabolic acidosis is associated with mortality as in association with progression of chronic disease. Evidence supporting bicarbonate therapy for slow chronic kidney disease, buffering, so preventing bone and intestinal status and knee therapies. Of course, you can use sodium bicarb, you can use citrate. About the bone mineral disorders that occur in chronic kidney disease: calcium, phosphorus, PTH, or vitamin D. Down, the amount of nephron mass decreases, we have more phosphate retention. As you know, when converting the hydroxyvitamin D to 1,25-hydroxyvitamin D, which is the active as the 125 enzyme. As renal mass decreases, there is decreased calcitriol activity, decreased production of 125-hydroxyvitamin D, which is in hypocalcemia because of the absorption of calcium from the gut, which causes hyperparathyroidism, cause further phosphorus, further calcium from the bones. Also common in CKD patients and of epidemiology recommends reducing lipid levels in high-risk population, and the lipid lowering therapy is considered the same as those for secondary prevention of cardiovascular disease. Four later, the patient returns and complains of 1 to 2 weeks history of edema. Blood sugar is 9/75. So what now? Yours and you that his statin has gone up to 5.4, calcium 0.8, Sp6. Creatinine ratio or urine albumin creatinine is 5.4. He also had urine protein excretion, it was 10.7 grams. No studies. Serum it was normal. Ethanol was done, which was within normal limits. Follow. It seems renal function has progressed rapidly. Earlier, we have to make sure we rule out reversible causes of function, which is volume contraction, medications, ruled out. That would be to maximize control of hypertension, which is or blocker, We may use diuretics for edema. We have to control diabetes with increasing amounts of insulin. In a stage 5 chronic disease, he needs to be referred to a nephrologist for initiation of dialysis in near future. Whenever you evaluate a patient with chronic kidney disease, you order BBC, you order basic metabolic panel, phosphorus, thyroid hormone, liver function test, hemoglobin A1C, and in the you ordered a UA with microscopy to see if they have any cellular gas. You are urine for microalbumin, spot urine for microalbumin, and measure a ratio. As you know, that a spot ratio is consistent to a 24-hour urine collection for protein and creatinine. It's a patient from the hassle of collecting and is all error in 24-hour urine collection. Renal ultrasound is of a basic work kidney disease. Briefly, what are the reasons for a patient to be referred to a nephrologist? If the ratio of albumin creatinine is more than 300 milligrams per gram, so this have significant proteinuria. Hematuria is not secondary to urological conditions, meaning it is not because of prostate cancer, bladder stones, BPH, identify a presumed cause of chronic kidney disease. So if you're not if the cause of chronic kidney disease, patient should be referred to a nephrologist for help. If this is for more than 30% in 4 months without an obvious explanation, manage complications such as anemia requiring erythropoietin therapy, abnormal mineral metabolism requiring phosphate binders, vitamin D preparation, serum 5.5. Others maybe slightly soft, but run them out altogether. Difficulty to manage drug complications. And minors should be referred to nephrologists, namely nephrologists, workup and treatment of their chronic kidney disease. Resistant hypertension is also there. So the key here is that the serum creatinine level is not enough. The top of chronic kidney disease is 140/80, 180 with proteinuria. Hypertension are the two most important modifiable riskers for progressive chronic disease. Some slides by J. Lee. Thank you. If you have, please feel free to ask me. I have a few minutes.